Good afternoon. It's a great privilege to welcome you to the Yale Law School as we launch the Salomon Center for Health, Law, and Policy. Today marks a very special moment in the life of this school. It is not every day that a school which is about 200 years old gets to begin something that is entirely new. Yet the Salomon Center is unique. There is really nothing like it anywhere else. It is an interdisciplinary venture with the core mission of pushing forward the frontiers of health care and policy. We are committed to the Salomon Center because we believe that the seismic shifts underway in the world of healthcare require ongoing, engaged, and forward-thinking analysis. The Affordable Care Act has and will continue to transform the healthcare industry. Already, more than 16 million Americans have gained coverage under the statute, with 137 million more guaranteed protective coverage. The healthcare industry presently accounts for more than 1/5 of America's GDP. When it is fully operational, the Salomon Center will be a training ground for lawyers and policymakers to acquire and to apply their expertise at a moment when their expertise is desperately needed. The center is wildly ambitious. It is the first law school center of its kind to focus on the intersections of health law, government, industry, and the practice of medicine. We have confidence in the center because its inaugural faculty director, the scintillating and dedicated Abby Gluck, is nothing if not intellectually brilliant and audacious. As her colleague, I can report that Abby is an astonishing faculty member, and I have no doubt but that her boundless energy and capacity will transform the Salomon Center into an international success. No problem is too daunting or too complex for Abby. The Salomon Center that we are assembling here this afternoon to celebrate is a new phenomenon in American legal education. It is an honor and a privilege to have with us today those who have created this center: Howard Salomon, his sons David and Andrew, and his wife, Sarah Salomon. The Salomon family is accomplished in ways that are staggering to contemplate. The family has touched the worlds of law, business, psychiatry, film, opera, and of course, healthcare. Howard and David, both Yale Law School alums, have built an industry-leading pharmaceutical company that has saved thousands of lives and introduced groundbreaking therapies. David, in addition to having a successful law career, worked for Paramount Pictures and produced the Peabody Award-winning documentary film Rebirth, which tells the stories of 5 remarkable Americans whose lives were dramatically affected by 9/11 attacks in New York City. Andrew, an alum of Yale College, is a professor of clinical psychology at Columbia University Medical Center. He is a widely acclaimed author and is presently the president of the PEN American Center. Among his many important books is an award-winning book called The Noonday Demon, The Atlas of Depression, which has transformed our understanding of the science and treatment of depression. Sarah spearheaded efforts to bring the acclaimed Russian conductor Valery Gergiev to perform in the United States just months after the collapse of the Soviet Union. From humble beginnings in the Bronx, Howard Salomon, who sold librettos as a young man at the Old Met on Broadway and 39th Street for 50 cents an hour, arrived here at the Yale Law School in the fall of 1949. He served as an editor of the Yale Law Journal, and he went on to practice law in New York City after graduation. One of Howard's clients turned out to be Forest Laboratories, a pharmaceutical manufacturer and marketer, but that was a company which he went on to build and to lead himself for nearly 4 decades. As the president and chief executive officer of Forest Laboratories, Howard transformed the firm into an innovative and industry-leading multi-billion-dollar pharmaceutical company. In due course of time, he brought in his son David to lead Forest Laboratories' business development and overseas operations in Europe, Canada, and Latin America. The impact of Howard and David has been global. Under their leadership, Forest Laboratories helped to introduce groundbreaking next-generation pharmaceutical products, including Celexa and Lexapro, which have helped to transform the treatment of depression and anxiety in the United States, improving and undoubtedly saving thousands of lives. Together, Howard and David now run the investment firm Hildred Capital Partners. It is that kind of foresight that led the Salomon family to establish the Salomon Center here at Yale Law School. The family understands the need to educate and to train future leaders in the healthcare industry. And they also understand the vision at the core of the center, which is to establish an academic institution that is focused on addressing cutting-edge problems in the real world. And we are so grateful to the Salomons for having chose Yale Law School to implement their vision. Over the next 2 days, you will see their vision come to life. The center's inaugural conference, co-sponsored by our School of Management, begins tomorrow morning, and it focuses on the massive changes in the healthcare industry that have arisen in the wake of the ACA. The conference is interdisciplinary. It brings together industry leaders, government officials, academics, private practitioners, and physicians of the highest order, most of whom are in this room, and many of whom are our alums. We are grateful to our conference speakers for being here, and we are inspired by what you have accomplished, and we're deeply honored by your presence here at this inaugural conference. This year, even though the center is only beginning right now, the center has already seen much success. We hosted a major conference on the 50th anniversary of Medicare and Medicaid. We established a career mentoring program for current students interested in healthcare law. And we are already expanding our course offerings in health law to include new courses in FDA law, public health law, the law of the healthcare industry, drug product liability litigation, bioethics, and our community lawyer program, which creates medical legal partnerships in which law students work alongside of doctors to serve the legal and health needs of New Haven's most vulnerable populations. It's fair to say, I think, that the center, even though it's just beginning now, has already become a focal point for students who are passionate about health law and policy. If you want to make healthcare policy or know about healthcare laws, Yale Law School, from this point forward, will be the place to be. It is Abby, of course, who makes all this happen. Professor Gluck is energetic, charismatic, deeply learned, and committed to the values that underlie the Salomon Center. And I should say, from a dean's point of view, she and the Salomon Center are a match made in heaven. As I turn the floor over to Abby now, I want to express my deep gratitude for her tireless efforts to make this day possible. She has approached the launch of the center with the same meticulous brilliance and dedication that she brings each day to this law school. We are deeply grateful to her for all that she has done and will do in the years ahead. Before stepping down, I just want to take a brief moment to say how personally thrilled I am to have with us this afternoon both Marna Bergstrom, the president and CEO of Yale New Haven Health Systems, and Secretary of Health and Human Services, Kathleen Sebelius. It's really an honor to host you both. Thank you for coming. So please join me in welcoming Abby Gluck.
what is there to say after what Robert just said, other than thank you, Robert. You give me way too much credit, as you always do. The person who really we need to thank is you. Our healthcare community could not have a more supportive dean and friend, so thank you for everything that you have done. So I had hoped to come up here with some good doctor-lawyer jokes, but as it turns out, there aren't any good doctor-lawyer jokes that talk about collaboration, and so that's not exactly in the spirit of the Salomon Center. So we'll work on that, but instead I will keep my comments very simple, and my duty here is just to thank a few more people and introduce the main event. But first, I do have to recognize the Salomons because it has been my great personal privilege to get to know Howard and David over the past 2 years. I've learned so much from them already. They are brilliant, they are kind, they're generous, and they really love Yale, and we are so lucky that they've chosen us to support. So thank you, Howard and David. I promise that we're gonna live up to your expectations, make this law school, make this center a place that is academically accomplished and grounded in the real world. So thank you. The center has also had some tremendous support from our dean's offices. Deputy and Associate Deans Al Klavoric, Mike Thompson, Mary Matheron, Joe Crosby, and also Jan Conroy and all of their staffs, and our incredible conference organizers, Renee DiMatteo, who literally delivered a baby on Tuesday and then came back here to work on the conference brochures, and true, and talk about health and law coming together, and Barbara Corcoran, and of course our center's very first senior fellow, Michael Ulrich. They've worked so hard to bring us to this moment. And now, a word about all of you and the conference ahead. Robert has already referenced tomorrow's conference, which is truly an unprecedented gathering of the very best healthcare leaders, academics, lawyers, policymakers, and physicians ever assembled, I believe, at a single law school conference. So we want to thank all of our speakers again for joining us, and we also want to thank our friends and partners across the university at the hospital, ISPS, Public Health, the School of Medicine, and of course, SOM, our co-sponsor in the conference, and my own partner, Professor Fiona Scott Martin at the School of Management, who has helped us bring this conference together and been a great friend to the law school for all of these years as we've built our center. Of course, as Robert has noted, the center is going to have an impact both here and outside the world. And this conference is being co-sponsored by Health Affairs and the National Academy of Social Insurance, two health organizations with widespread influence outside the confines of New Haven, and we hope to continue those partnerships. Now, many of you in the audience, including many distinguished alums of this law school who have come back, went to law school at a time when there wasn't such a thing as health law at a law school. And so you had to learn health law by the seat of your pants. Maybe you were lucky enough to find a professor, someone like Jerry Mishaw or John Simon, who are in this room with us, who took you under their wing and taught you health law before health law was a thing. American law schools have taken far too long to recognize health law as something central to the law school curriculum, but we are here now, and we want to thank all of you who paved the way for us before, and we want to invite all of these, our alums and friends across the university to connect with the center and be part of our programs and our future. Lastly, I have to thank our wonderful, fantastic, marvelous Yale Law School students. When I moved here from Columbia Law School a few years ago, there were some very eager students who found me before I ever walked in the door. It was July, I was 9 months pregnant with my third child, and they wouldn't take no for an answer. They wanted a health center, and they wanted one now. And they have succeeded. They have created a student organization and a program that is the envy of all of their peer schools. Many of those very pushy, wonderful students have come back to join us tonight. Gabe Scheffler, Julian Polaris, Maya Hodis, and others, thank you. And I want to thank these are all my wonderful students who helped form the center. And I want to thank the plan for the evening and for tomorrow. The all-star presentations will continue tomorrow from 8 to 5 p.m. with breakfast at 8 a.m. here at the law school in room 127, and all of the events will be here at the law school. We'll be discussing the major changes to the healthcare industry, as Robert said. I hope you will join us. Tonight's program is as follows. We will have our keynote address, and although it is not my role to introduce Secretary Sebelius, I cannot resist a moment to say thank you for coming, for being so generous with your time with our students today, and for being such an incredible public servant to the country. So thank you. Secretary Sebelius has also offered to take Q&A after her remarks, so we'll have that audience Q&A, and then we'll adjourn right across the hall to the law school dining room for a cocktail reception. If you are coming to the conference speaker dinner, just a reminder that there will be a shuttle bus right outside the back door of the law school at 6:15, and an earlier one at 6 o'clock over to the dinner location. So now it is my great pleasure to introduce Marna Bergstrom, the president and CEO of Yale New Haven Health System and CEO of Yale New Haven Hospital. She will introduce Secretary Sebelius. Marna began her career at Yale New Haven more than 36 years ago as an administrative fellow after receiving a master's in public health from the Yale School of Epidemiology and Public Health. And she's continued to rise, and since 2005, she's led the entire system, which employs more than 20,000 people. Marna is the ideal person to kick off this event, first because, of course, in line with the conference focus, Yale New Haven Health has experienced its own pressure to become more cost-effective through consolidations and acquisitions. But Marna and her team, including her general counsel, Bill Azeltine, also exemplify the kind of collaborative spirit that our new center will embrace. The hospital, along with the med school, led by Dean Alpern and Paul Tahiri, have been wonderful partners for us in our program and our research and our goals in creating more just access to health and exploring the link between law and health through medical legal partnerships, through joint course offerings, and through many research collaborations that range from cancer to pharma to the Affordable Care Act. So thank you, Marna, for kicking us off. Thank you, Secretary Sebelius, for coming. Thank you to all of you for being here, and we hope we enjoy the rest of the conference. Thanks.
Thank you, Abby, and wow, to introduce an introducer of a speaker is quite a privilege, and it is a pleasure to take part in the launch of the Salomon Center for Health Law and Policy at the Yale Law School. This is clearly an important endeavor. Healthcare is inherently interdisciplinary, as we know well, and we need knowledgeable and informed lawyers and policymakers now more than ever at this critical moment of system change and reform in healthcare. As you've heard, tomorrow's conference is going to focus on how much the healthcare system has changed and will be changing in response to market, political, and regulatory forces that are driving integration and consolidation like never before. At the Yale New Haven Health System, we, like other providers, are striving to stay ahead of the curve, focusing primarily on how we can deliver unparalleled value to our patients and the communities we serve. And we define value as the quality and safety and patient experience we offer divided by the cost or the price point for those services. Among our many collaborations led by our General Counsel, Bill Azeltine, to improve the health of communities we serve is our collaboration with the Yale Law School. We've implemented several medical legal partnerships together, and I know that other projects are already percolating to serve people in our communities. So we're especially delighted and appreciative of the Salomons to see the center come to life and look forward to more opportunities to work together. But now the main event, because I am really pleased to have the privilege of introducing U.S. Secretary of Health and Human Services and the former governor of Kansas, Kathleen Sebelius. Secretary Sebelius has played such a central role in shaping where we are right now in the U.S. healthcare system in so many different capacities, and as you'll hear, very relevant to the work of this center. After receiving her BA from Trinity Washington University and her MPA from the University of Kansas, Secretary Sebelius began her public service career as an elected official with 4 terms in the Kansas State Legislature. In 1994, Secretary Sebelius was elected as Kansas's insurance commissioner, after which, in 2003, she became the governor of Kansas. She was known for her pragmatic, bipartisan approach to solving Kansas's pressing fiscal issues while still improving public services. She led Time magazine in 2005 to name her one of the best governors in the United States. In 2009, President Obama nominated her to become the 21st Secretary of the U.S. Department of Health and Human Services, where, upon confirmation, she was immediately tasked with the small project of coordinating the government's response to the H1N1 pandemic, and then, of course, the effort to pass and implement the most important health care legislation in half a century, the Affordable Care Act. Secretary Sebelius oversaw every step of the Affordable Care Act's rollout. Under her leadership, millions of Americans have gained insurance coverage, many for the first time in their lives, and eliminated insurers' ability to discriminate based on gender or pre-existing conditions. Secretary Sebelius helped us take an enormous step forward as a healthcare system that is accessible and affordable and more effective for all. Today, Secretary Sebelius heads Sebelius Resources, a company that provides strategic advice to private companies, nonprofit organizations, higher education institutions, and financial investors. We are fortunate to have one of America's foremost experts on national and global health with us today. I can't think of anyone more qualified to be the first speaker at a center dedicated to the intersection of law and policy and government in healthcare and the practice of medicine. It's an honor, and please join me in welcoming Kathleen Sebelius.
Thank you very much, and good afternoon, everybody. It's a great privilege of mine to be here at Yale, and I want to echo a few of the comments already made, thanking the Salomon family for their generous vision that having a center for health policy and law made sense at this particular period of time, and as you've heard, a one-of-a-kind center in the country. I want to thank the dean and certainly Abby Gluck. Abby accosted me in a women's bathroom at another university after I gave a speech, and she said, "You have to come to Yale," and I've heard that from her on a regular basis until I'm here today. So thank you, Abby. She is the right person at the right time for this job, because I can tell you she's nothing but tenacious. So I'm eager to see what's going to happen. I know that the program that you will have a chance to participate in over the next 2 days is pretty dazzling. The expertise and breadth of knowledge and experience of the speakers and presenters is really a tribute to how important this center is going to be, and the fact that people were eager to come and be part of this. And I think the themes of consolidation, integration, and competition are exactly the right notes for this discussion, because those will clearly be front and center. And there isn't a more relevant time to have this kind of gathering of expertise who will not only inform students and others about the ongoing work, but have a very significant impact on the public dialogue which is about to unfold. And finally, to the students, we want to urge you to hurry up and graduate and come out and become the leaders that you're being trained to be, because there is no time in our country where there has been more need for people who emerge from a discipline with a integrated knowledge of the impact of law on health and health on law and what business means to all of that, and can bring that expertise both into the courtroom but into the policy offices across the country. I don't think it is an exaggeration, although I'm known to exaggerate a time or two, to say that we're in the midst of probably the biggest transformation in healthcare in at least 50 years. And it's underway not just in the area of the new law that has been passed, but in a whole variety of areas. But before I get into that particular look, I have to confess a bias. I do love lawyers. Actually, I'm certified to love lawyers. I married a lawyer. Our older son is a lawyer. For 8 years in one of my former lives, I was the executive director of the Trial Lawyers Association in our state. I have seen the practice of law through very personal lenses, but more importantly, and maybe equally importantly, through professional lenses. There was no question of the role that lawyers played at every step along the way in my policy career. And I am a believer that having the lawyers at the table from the very beginning, framing the issues, driving the policy, helping to achieve goals along the way is really the only way to get good results. And I have been a huge believer in that. And so I am thrilled to be here at a time where this new center is being launched. I want to talk for a little bit today about the Affordable Care Act, but mostly on the part that's a little bit underneath the surface. I always liken it to watching synchronized swimming, where a lot of the attention is on the bathing caps, but there's a hell of a lot going on underneath the water that is actually making those bathing caps stay up. And I think that is potentially the most potent part of the reframed health law, and one that will unfold over the next decade or two. A little bit about the role of lawyers that I saw in one of the largest domestic agencies in the country. HHS has an incredibly broad scope, and I was pleased to hear about the new courses that are being initiated here, because this is really not about, health law is not about the newest bill passed, but about this range of issues where health is a central component, but they affect policies across the board. And the role that litigation and lawyers have played in actually blocking, stopping, having an influence over some of the positive work going on. And finally, some of the changes that are underway that I think will play out into the future. So in fairly simple terms, you'll be pleased to know I did not bring a PowerPoint for the 2,000-page Affordable Care Act, or I don't intend to take you through the budget of the HHS, which is only $1 trillion at this point. But simply, the Affordable Care Act, I would say, has three primary goals. One was access to affordable coverage for the slice of the marketplace who did not have insurance at all or didn't have affordable coverage in their workplaces. The second really was delivery system reform, which is a fairly innocuous term that means actually changing the way medicine is practiced to deliver better outcomes, changing the underlying profile of the United States, where we were spending and continue to spend almost double per capita any nation on earth in terms of healthcare expenditures, and have fairly mediocre health results if you look at them as a national component. And the third goal really was to slow down the trajectory of health inflation, which was running double GDP and had for decades been moving well ahead of any other segment of the economy, and do that really through improvements in the system, not by cutting costs and cutting benefits and shifting those costs, but really looking at the underlying costs of healthcare. And I would say that while I'm not the most objective observer, we are now 5 years from the signing of the law. And in terms of access and coverage, there's no doubt that the Affordable Care Act is working for that piece of the puzzle. There are about 20 million people as we begin enrollment number 3 who have either signed up in marketplaces for insurance coverage or are part of expanded Medicaid, like here in Connecticut. And 17 million of those folks had no health insurance before the law was passed. We've had the biggest drop in uninsured that this nation has ever seen. We're now below double digits for the first time ever since it's been counted, and those numbers continue to go down. So I think that there is a definite success in the 2 years that people have been able to enroll and engage in coverage and access. In terms of delivery system reform, those results are just beginning to happen. And delivery system reform from the federal government level is really about using the $1 trillion $1 trillion that is spent every year by the federal government on healthcare, and trying to align for the first time that expenditure with health outcomes, as opposed to paying by procedure, paying fee for service. The more you do, the more you get paid. You do more stuff, you make more money. That has been the traditional way government has paid for services. And this really begins to shift that. And to tell you how fast that shift is occurring, there is now a timetable that has been published where the Center for Medicare and Medicaid Services that tied 0% of their payments to any kind of quality measure in 2011 is now at about 20%. The goal is 30% by 2016 and 50% by 2018. And the rest of the payments will have various kinds of quality measures. Now, if you think about $1 trillion of expenditure in contracts with every doctor, every hospital, every drug company, every device company, that's a major shift in policy, and developing what quality measures look like, how you decide what's working and not working is a huge piece of the puzzle. But that work is very much underway, and there are already some encouraging signs. Hospital infection rates in hospitals across the country have gone down by almost 20% in the first 2 years. And that was one of the measurement goals. The number of preventable readmissions, how many people actually within 30 days were back in the hospital. Some of those are due to a health crisis. Others are due to the fact they never talked to a provider in the intervening 30 days. No one followed up with them or checked on them. And that rate is, again, down dramatically, saving lives and saving dollars. There are early signs that the formulation of doctors and hospitals being paid differently is beginning to show results. Improved care and lower costs. The number of elective C-sections, which in this country were astoundingly high, elective C-sections, has dropped by almost 80%. Payment to quality and tying those together and measuring those across systems is beginning to show results. And finally, in the cost area, the third big goal, health inflation is at the lowest level in this country in 50 years. It is rising more slowly than it has over the last 50 years. And that initially was seen as part of the recession, and then it was said, well, we don't really know what's going on. And now people are saying there really is something going on. There is a more systematic change. And while there bump up in costs last year, drug prices and more people using the system, it is still significantly below. And I would say that it's well below the pre-ACA rate, which was really running double GDP. So there is some very encouraging work, and I think the real target is the ongoing delivery system reform. Can you intervene a lot earlier with chronic illnesses, which drive a lot of the cost? Is there a more effective way than emergency room care to get health care to people who need multiple disciplines? Can you put primary docs back in the role of being the patient and care coordinators in a way that they haven't been for years? And part of that is establishing now an electronic health record platform that did not exist at all prior to 2008. Across this country, now the vast majority of hospitals, it's now up to 75 to 80%, and the vast majority of doctors are using electronic health records. They still are not fully interoperable. That is definitely the top priority on the horizon, but nobody was even talking about interoperability as recently as 5 years ago because there wasn't anything to be interoperable with. It doesn't really matter if you have, Tom Brady and Peyton Manning as the quarterback. If there's nobody downfield to receive that pass, you can't make much gain. And that system is now being put into place so you can measure and look at what is happening, not just in one hospital or one system, but across the board. Identify cost outliers and, frankly, protocol outliers, and begin to hopefully encourage more healthcare providers to follow the known protocol day in and day out and pay people for the first time, keeping folks healthy in the first place and not waiting until they get involved with acute care. I had one of the most amazing experiences that I think anybody will have. I was the 21st Secretary of Health and Human Services, but I would say being in this administration at that particular period of time is an experience nobody else has ever had. Being with the president who passed this kind of comprehensive proposal was amazing, and then working on the implementation, including the website, which was a lovely experience. I hope you all are spared that, but it did get fixed. People did get enrolled, but even that, and coming out the other end with millions of people enrolled. But I think the discussion that the dean had earlier about the new classes which are being now contemplated give you some idea of the breadth. Health law is really not about this new particular bill that was passed. But the Department of Health and Human Services is a very broad agency at the federal level and encompasses everything from global health issues, the Food and Drug Administration, which now regulates products accounting for 25 cents of every dollar spent in America, is a product that comes under that regulatory umbrella, and the issues related to that. The National Institutes of Health, which by anybody's measure here or abroad is the gold standard for research and driving a lot of the new discoveries involved with personalized medicine and precision medicine. The Centers for Disease Control and Prevention, which is a global public health agency that is now being mirrored around the world and has employees in 50 countries working on everything from global health security to training doctors and nurses, and CMS, the Centers for Medicare and Medicaid Services, which now covers 1 out of 3 Americans have their health insurance either with Medicare or Medicaid, the largest insurance company arguably in the world. And all of those are under the purview of one department, and all of those involve an intersection of health law and policy in very different ways, but in very critically important ways. And they affect most Americans every day, whether they know it or not. The food they eat is affected by the FDA's food safety issues. If you take your child to child care and have a center that is under a federal regulation, that is impacted by the Department of Health and Human Services. If you have a parent or a loved one involved in Medicare, they are involved and implicated. There are clearly daily interactions that people don't know, and it's one of the reasons I think that this center is so critical. Definitely healthcare accounts for 17% of our economy, but it also is probably one of the most personal services any of us will ever interface with, and we rely on it and depend on it each and every day. And there were always, beyond that scope of 11 operating agencies with its range of issues and problems, there was always something interesting, challenging, and sometimes terrifying coming over the transom. You heard about my initial move with, and Marna talked about H1N1, which now seems, once we got into Ebola, it was like, oh, that's old news. More people died of H1N1, luckily, than Ebola in this country. But H1N1 was this virus which was killing children and young adults. There was no vaccine. There was no real identification, and we had not had a pandemic in the world in 40 years. So there was really no experience of how to deal with that. And my first day on the job, which was carefully planned, I was the governor, the sitting governor. The Senate was going to take up my nomination on the 28th of April. We had a plan that hopefully I would be confirmed. I would then get the lieutenant governor sworn in, he would become governor, I would fly to Washington and start my new job. And at 10 o'clock in the morning, I was in my office in Topeka, and the phone rang, and there was a person on the other end of the phone from the White House saying, there is a plane in the air, it will land in Topeka at 11 o'clock, and the president wants you on that plane. I said, well, that's great, but we have a plan. And my plan is that I'll get I'll get confirmed, we'll get the lieutenant sworn in. Not amused. They just repeated, the plane will be on the ground, you need to be on the plane. So two things. One was I was reminded I had a boss again. I didn't have a boss for a long time. But secondly, it reminded me that I had no idea really what I was getting into. And so I literally left. I'm not sure those of you who are lawyers in the room would think this was even a legal document, although we had it notarized. I left a note on my desk in Topeka that said, in the event I am confirmed, I hereby resign as governor. Because I really didn't want to leave it to chance. When I arrived in Washington, I had no idea where I was going. I was greeted by somebody who said, oh, you're going to the Oval Office. The president is going to swear you in, which happened. And then I was taken to the Situation Room, and my literally first hour on the job, I was on a phone call with Margaret Chan, the director of the World Health Organization, with the Mexican health minister and the Canadian health minister, where information was being shared about what we knew and what we didn't know. And it, again, was a reminder that this was a whole new territory, because I'd done a lot of things in Kansas, but I'd never dealt with a pandemic before, and it prepared me for what was coming. We had a situation with a Chinese baby that was, again, brought to my attention by the State Department. I got a call one day that the general counsel had to come see me, and he came into the office and said, there's a baby, and the State Department is demanding we have to give the baby back. I said, what do you mean I don't have a baby. Do you have a baby? Where's the baby? And it turns out that an American couple who had previously adopted a Chinese child had adopted a second Chinese child, had come out of China with this little girl, and were in Chicago. And the Chinese government was asserting that this adoption was not legal, that they had broken the law, and they had basically kidnapped the baby, who was now in Chicago in American jurisdiction. And since we are over the Children and Families Program, that we had to take custody of the baby immediately, put the baby in foster care while the decision was pending, and then send the baby back to China. Ultimately, it was resolved, and unfortunately for the parent, they had broken the law, and they had essentially taken the baby out without the proper documentation, and we did ultimately have to return the baby. But we had a pending international incident that we allowed to be resolved in the court in China and the court in the United States sort of simultaneously, and they both came up with the same result. But again, just a reminder to me that there was always an issue that you weren't prepared for, couldn't deal with, and had to make a judgment call on. The final one, which I'll mention, which is still pending, and you'll see something about this, and those of you who are involved in litigation or law around research may get into this, but it's the so-called dual purpose research, where scientists were altering the genomic sequence of various specimens to see if various kinds of lethal materials could then be transmitted human to human. We had various disease strains which were not showing a propensity. They could be transferred from animals to human, but not human to human. And there was one set of arguments that made the case that this was incredibly dangerous, and it could be used as a bioterrorism weapon, and if indeed the scientists were successful in figuring out human-to-human transition, we would have just created one of the most lethal ideas that any bioterrorist could use on the United States. Others suggested that unless we knew how that happened, and unless we then could begin to develop countermeasures, you would never have any safety or security, because somebody was going to do this eventually. Somebody was going to figure this out, and we should be out ahead of that. And Again, issues that were fascinating, complex, no easy answer, but it really took, it's the combination of bioethics and business and research and law and very, very complicated decisions along the way, and those will continue to come up. We had lawyers at every point along the way who were on the other side of every argument I was ever involved in. The day the president signed the Affordable Care Act into law, the first Supreme Court challenge was issued. The lawyers for the tobacco companies blocked immediately the FDA's authority, which they had finally achieved after 25 years of trying to get a bill through Congress in terms of regulating tobacco. So there were always teams both trying to move the mission and trying to move in a different direction. And again, knowing what the framework of the law was, we had a lot of issues where the statute was not totally crystal clear. I needed a creative legal team working with me to say, here is the goal. I don't want to break the law. That's part of your job. But the default position can't be, you can't do this because we can't figure it out, because we could never make any progress that way. So I will work with you, but we have to figure out how to get from here to here. And if this door closes, what other doors can open? And how can we move along the way? And those were constantly parts. You had policymakers and legislators, but a critical component of any progress that was made, both when I was governor and certainly when I was secretary, was always that creative legal team at the table using all of the possible framework of often existing legislation to move the ball forward. And I was impressed every day by their skill and by their tenacity. At least on the government side, they were very much overworked and underpaid, but incredibly important and often the unsung heroes of any success. They were not necessarily the ones whose name would go behind a piece of legislation or who got the praise and glory of leading the agency, but they figured out how to solve problems over and over again. I think the topics of the conversation that you're going to have in the next 2 days are ones that are critical for the future. Consolidation. I know Connecticut will be front and center as a state in the insurance mergers. Connecticut will be the lead state in the Anthem-Cigna merger. Wisconsin has the lead at the state level in the Aetna-Humana merger, but the issues around is consolidation, positive or negative, either with insurance companies, but hospitals, with hospital and doctor groups, with drug companies, with pharmacies. Consolidation was underway prior to the passage of the Affordable Care Act. It's picking up steam, and I think whether or not that is a positive trend, a negative trend, or a case-by-case trend, which has to be analyzed, is something that is a very important discussion. Who benefits, who loses, who is the beneficiary if you save money? Is it ultimately the patients? Is it the providers? Is it the hospitals? Do people have fewer choices or less choices? And what role should competition continue to play? I was talking to a number of law students about, I think we are beginning to see, it won't come to fruition for a while, but a perfect storm brewing around drug pricing. This discussion is not new, and it has been around the American health system for a while. But I think what is new is this transparency around prices set by various drug companies for various drugs. Nobody's really known that in the past and can't see it that clearly. But also, the question is, how much is too much? And if too much is decided, who makes that decision and how do you make that? I think it's very appropriate that the Food and Drug Administration never be allowed to consider price when they are looking at drug approval. I think that would be a terrifying result, that they would actually put pricing into their consideration of whether a drug should come on the market. But we, again, remain one of the only countries that doesn't have some other entity actually looking at drug pricing. And our consumers often are paying for research that starts at the NIH, that ends up going into the private sector. Drug companies often are putting a lot of money behind research and development, which is benefiting people globally. But when the final product comes back on the market, our consumers pay far more than anybody else on earth to get that drug. And whether or not there is going to be some regulatory authority, whether that's appropriate, at least for Medicare, which is the only federal agency right now who cannot negotiate for drug prices, but they are the largest purchasers of drugs in the United States. So I think you're beginning to see insurance companies, doctors, patient groups, legislators, and others talk about this in a way that I haven't heard for a very long time, and I think that will be unfolding as we go forward. The integration of technology into healthcare is really relatively new. When you think of services that have been disrupted by a variety of technological advances, made easier, made cheaper, made more accessible, healthcare in many ways has been pretty impervious to technology for a long time, and that is beginning to change. And I think that pace of change will pick up. Data analytics, analyzing what are the most effective interventions, how early can you identify a pre-diabetic, does an intervention at that place make a difference in terms of what happens in the future, I think will become very much more a part of ongoing healthcare delivery. The analysis of what's happening within systems, what's happening within diseases, we still have a picture, the way most countries do, where chronic diseases are very costly, not only in terms of shorter lifespan, but also in terms of overall dollars spent. And the two underlying causes of chronic diseases are smoking and obesity. So how, either through medical intervention, societal intervention, laws, policies, you can influence those two presentations and change the trajectory, because right now one of three of all of our children are overweight or obese, and 3,000 young Americans under the age of 18 smoke their first cigarette every day. That's not a good health profile for our economy, and it's a terrifying health profile for our country. So changing those issues and figuring out through policy, through healthcare delivery, how that happens. And finally, I would say the focus on precision cures and personalized medicine are just beginning to be understood, and that explosion will continue on into the future. Designing drugs that have a target based on your DNA and your particular presentation of a disease have dazzling life-saving potential, also cost issues that I think we haven't even begun to contemplate. So this is an amazing time to be in both healthcare and in healthcare law and policy. Huge transformation on the scientific front, delivery system front, insurance front, consolidation front underway. And I would just say there really aren't any good old days to go back to. They don't exist. There's a lot of revisionist history that always goes on, but returning to 2005, 6, 7 is really not a great profile. I think the goal will be is how do we move forward in a more productive manner? How do we begin to, again, change the overall profile of the United States. So we not only have great health care for some of the people some of the time, but we have great health care across the board for more of the people more of the time. We take advantage of the dazzling scientific discoveries, but also the kind of health care advances that the United States has done so very well. The pace of change has got to accelerate. So Americans don't keep living sicker and dying younger than our global competitors. But I don't think there's any more important focus for our economy and for our country than figuring out this puzzle going forward. So I'm, again, delighted to be here at the launch of this very important center. And I want to thank, again, the Salomon family for their generosity in launching this really critical program. And if we've got time, I don't know what our timetable is, but if we've got time for questions, I'd be happy to take some questions for you. Thank you. Abby shook her head and said there was time. So if anybody has, yes, I think there are 2 microphones.
Hi, Ms. Secretary. Thank you for your work on behalf of bringing the Affordable Care Act to life and for your service to the country. I'm a primary care doctor, and as soon as the act rolled out, I became distressed at the tinkering that the insurance industry was doing with their products, particularly deductibles going up and networks narrowing. And as a primary care doctor, that's had a big impact on how easily we can care for people, where we can send them for their care, if they can even get into our office. And I'm wondering what the solutions are to that, and whether the exchanges have any statutory power to ask the insurance companies to maybe play a different game.
Well, it's a great question, and I think there are a couple things going on. There have always been some high deductible plans on the market, but those are becoming, again, kind of front and center. And part of the issue is, I think, to get individuals some more information and knowledge about what that means, because people, particularly a lot of folks who have never had insurance before, have no idea how to do sophisticated. It's hard to choose a network if you've never had a doctor on a regular basis. It's very difficult to look at anything but a price point, which is a logical place to go. But if you don't understand then what that price point means and how much out-of-pocket costs. So the law had a limit on overall yearly out-of-pocket costs. That helps, but not nearly enough. The issue of narrow networks is actually one that there is a new regulation now being revised and pending on to actually broaden the network authority in